Good morning, everyone. First of all, thank you for having me, and I just would like to say that I'm the 0.1% of physicians in the United States. I'll start with that. Just because what we practice is really not standard of care yet, and hopefully it will become standard of care. So first of all, I want everyone actually to stand up just for a moment. And this seems like a futile exercise, but the reason I'm saying this is because 1 out of 3 of you in this room have a gene in which when you sit for more than a couple hours, you start to make more of an inflammatory cytokine called IL-8. In this room, I just want to raise of hands, who is uncomfortable sitting for more than 2 hours? Is it about 1/3? Look around, people. Keep your hands up for a second. Keep your hands up for a second. It's about 1/3 of us. That's genetic. So those people that just raised their hands, I can confirm that with genomics, and I can also mention that you might want to get a standing desk if you don't already have one, because it would actually reduce your inflammation. So I'll have everyone sit down. Thank you very much for that quick exercise. Let me see if I can find this. So what do I do? I got trained traditionally. I was an academic professor for Mercer University in Savannah, Georgia. I loved it there. I worked for 10 years in a hospital setting as an academic hospitalist, and I used to have rounds of residents and pharmacy students, and we would do all the academic stuff, and it was fantastic. And we provided excellent care. We would get people out of hospital in 48 hours. And I'm sure all of you know this. How many here are actually providers? Can I have a raise of hands? A few of us, okay. And how many here are in the payer services? All of you, maybe? So the reason I'm asking this question is because as a provider, you're taught in medical school how to provide the best care for most people most of the time. And that makes sense. But what about the people that don't get improved? What about the 25% of people that don't get better and that burden our system with chronic disease? That's where I'm going to talk about. And so when I got trained in traditional medicine, I then realized that we couldn't help some people. There was a big burden. And the Cleveland Clinic had just started something called the Functional Medicine Program. And I got trained and vetted through the Cleveland Clinic in functional medicine. And I realized that there were other avenues that we could take, although initially more expensive, would save hundreds of thousands of dollars in the long run with just a few patients, because we would actually find the actual root cause. I'm sure you guys have heard of root cause medicine. That's what we're going to talk about today. So there are actually published studies on this. This is a study from the Cleveland Clinic that took 7,000 patients that were treated in the functional medicine model, and all of them had much higher performances versus the controls in quality of life metrics. They all felt better. They all did better. They had less fatigue. They slept better. They had less gastrointestinal problems, less inflammatory problems. So this model works. This is an example of one disease called rheumatoid arthritis. I'm sure everyone knows who that is. Very, very common inflammatory arthritis. 318 patients were treated with a functional medicine model, which is in addition to the traditional model. And of course, they had significantly improved outcomes, less pain, less inflammation, less relapses, less occurrences, less admissions to the hospital, less hospital visits, less clinic visits. So this makes sense. So when people say, what do you do as a functional doctor? What makes you different? Well, I said, first of all, I order a lot more testing, because the average doctor will order a CBC and a CMP, some basic lab work, and I have this array of testing I can use. And for the simple fact that I'm only going to be here for not the longest period of time, I'm going to talk about those 3 bolded areas: genomics, which is an emerging field of medicine; heavy metal testing, which is not taught in medical school; and pesticide testing, which is not taught in medical school. Has anyone in this room ever been tested for heavy metals? One person. Okay. Has anyone in this room ever been tested for pesticides? One person. Now, who do you think in this room, of all these people, how many people would you guys guess have heavy metal toxicity right now in this room? If I just took a random sample of everyone's blood. It's going to be hard to tell, but I would tell you it's about 1 in 5. That's a lot. We're talking about mercury. We're talking about arsenic. Oh, we don't have arsenic in the United States? Yes, we do. But we're going to get into that conversation in a second. Let's talk about genomics. Genomics, as you know, is a study of your DNA. So simple, we just take a swab of your saliva, we send it off. Multiple companies now can do a array V-chip analysis, 250,000 mutations. So just so you understand, we all have 20,000 genes, and 99% of them are identical to a chimpanzee. But we're not chimpanzees, right? We're a little bit like chimpanzees, but pretty different. So that's because we have the 250,000 mutations, or epigenetics, above genetics, that are differentiating our expression into a human being versus a chimpanzee. So this is really what sets us apart. So we get one copy from your mom and one copy from your dad. So if you get the perfect copy from your mom and the perfect copy from your dad, you don't have disease. If you get one disease copy from your mom and one disease copy from your dad, you're going to be sick. But if you only have one disease copy, that's where genomics comes in. We go, well, you're not going to be that sick, but you're going to have problems. And we can actually, and if you have enough of these, because there's 250,000, so if you have 5 or 6 or 7 of the right haplotype SNPs, a haplotype is a combination of genes that increase your prevalence for disease, then you might have a 5-fold increased risk for Alzheimer's dementia. Would you want to know that? Would you want to know you have a 4-fold risk for stroke or 10-fold risk for diabetes? And we can predict these things at the time of your birth. So you can literally modify your entire environmental, everything. You can affect how you eat, how you exercise, what supplements you should take. It's so amazing what we have at our discretion. And now, genomics, when the Human Genome Project occurred, we didn't know what we were doing. Okay, the person who helped develop the tool that I work with is a Harvard physician who has a team of PhDs, who has 10,000 studies. Most of them are evidence-based, tier 1 or tier 2. This is strong evidence. So I think we have enough evidence now to suggest that we can really start using genomics as a clinical application tool. So again, if you have an odds ratio for disease, it helps. So for example, if I see a patient and they have an odds ratio of dementia 2-fold, that's pretty significant, right? Everyone has 1-fold or 1 odds ratio for disease. If someone has 5 odds ratio, I'm concerned, and I'm going to act very proactively. I'm going to get an MRI when they're 50. I'm going to put them on an intermittent fasting diet. I'm going to make sure the A1C is very low, below 5.2, keep their sugar down. So there's all these things you can really do nowadays that we're not aware of. The reason I'm bringing this up is because of this. We have the 2nd highest GDP in the world. We do pretty well, okay? But we spend 1/5 of that in healthcare. Now, I'm actually pretty impressed with that. I think it's great that we spend money in healthcare. I want to spend money in my healthcare. But this is the problem. 90% of that spending is on chronic health conditions and mental health conditions. So we're losing the battle, and we could be a little bit more efficient. This is another point that I like to mention. Compared to all other industrialized countries, we're spending 2 times as much on healthcare, which is still impressive. Listen, I'm proud of that. We can do that. We have the money to do that. That's great. The problem is we're off the graph. This is a graph showing how much we make per person. Average in the United States, $63,000, yet we're spending $12,000 a year on healthcare. That ratio is a little bit steep for some people. The other problem is, compared to every other developed country, London, Switzerland, Germany, we are living 4 years younger across the board. So we're spending twice as much, but we're not living as long. So that made me scratch my head and go, what are we doing wrong? Is it the air we breathe? No, well, we're in a pretty clean area. Is it chemicals? Is it food? Maybe it's the food. So I started thinking, what about the pesticides? Are the pesticides a problem? And functional medicine has detailed this in great detail, so much data behind this. Because we use more pesticides, you see all those diseases? Parkinson's, infertility, birth defects, allergies, otitis media, ear infections, preeclampsia, hypertension with pregnancy, metabolic syndrome, which is an underlying problem that develops into diabetes at $300 billion a year. Obesity, $260 billion a year, non-Hodgkin's lymphoma. And because we're over-farming, and by the way, so when GMO crops were created, they were created with great intentions, and they did a great job. We feed the whole world, essentially, year-round. We have crops that can literally grow in any condition. And the problem with that is when you grow a crop year-round and you don't give the soil a rest, you deplete minerals. So we have that problem. So this is just showing you that compared to other industrialized countries, we use 322 million pounds of banned pesticides per year. Yeah, Europe is not using these pesticides, but we are. And I think this is a problem. And so obesity is a $260 billion issue. Well, did you guys know, I don't know if you knew this, but they did a little research. If you ate organic, which means less pesticides, you had much less obesity, metabolic syndrome, preeclampsia, lymphoma, birth defects, allergies. It's ridiculous. Infertility. So there's no question now that we have enough data showing, this is another study from Thailand, that if you were an agricultural worker, you had a lot more disease and a lot more obesity. Obesity is the underpinning problem in America. So you keep looking at all these things and you go, okay, pesticides equal obesity, weight gain, endocrine disrupting chemicals. Why does every man that I see in my clinic, not every man, but I say 1 out of 3, have low testosterone? Why do all these young women have irregular periods, low progesterone, infertility? Because we have a lot of endocrine disrupting chemicals, which are pesticides. So now that I've gone on this negative tangent and everyone's depressed, we're gonna pivot a little bit, but right before I pivot, I'm gonna go a little bit deeper into depression, okay? Glyphosate, it's the world's most widely produced herbicide. 700 different products in agriculture. It's used everywhere. You guys have used Roundup, I'm sure, once in your life. Roundup has glyphosate. Glyphosate's being sued every way possible because of these things. And lymphoma is the biggest thing. But now we're having pancreatic cancer, skin tumors. It's got, and not to mention autism, which is a huge problem, metabolic disorder. And the prevalence of autism has been skyrocketing. And people don't know who to blame. Is it this? Is it that? Is it childhood diseases? Is it vaccines? It's pesticides. We have so many problems that we can target, but we have to be aware of the problems to begin with. So how do you check for glyphosate? When I was in medical school, I never learned about glyphosate. Lawyers taught me about glyphosate. I didn't know about glyphosate. So then I said, well, functional medicine knows about, well, that's interesting. So, do you guys know that in medicine there's not a field of environmental specialty? So you can't go, I want to be a doctor and be environmental specialist, or I want to be a toxicologist in environmental, you can't do that. There's toxicology, like if you've been poisoned with certain drugs, but there's not environmental toxicology. Why is that not a field? It blows my mind. And so functional medicine is trying to bring this out. So functional medicine goes, well, what if we use CLIA certified labs, FDA cleared for accuracy, and they do, and we start measuring people. So this is most of my patients, guys. 70% of my patients have undetectable glyphosate or such a low level of glyphosate that it doesn't matter. It's less than the 75th percentile. I don't care. It's not going to bother them. But then every so often, I decide to run genomics on people, and I consider this a matrix because I feel like I'm cheating. I'm like, well, I don't know what's wrong with you, but I'm about to tell you what's wrong with you. And I take the red pill, I dive down the rabbit hole, and I go, okay, look at this. Most of my patients are okay. These are the genes that produce something called glutathione. Most people don't know what that is. Glutathione is the master scavenger of toxins. So, genetically, 70% of you in this room make plenty of glutathione. And as you can see, that means that 70% of you are going to have normal glyphosate levels. But what happens to the other 30%? Now, this is a study showing you that this is proven in toxicology. Glutathione is required for pesticide removal. I'm not making this up. Here is a 30%. Now, this specific one is a 1 in 5 gene, so this is actually 20%. 20% of Caucasians, and this is just different, it's different for different races, have a deficiency in glutathione production, okay? So if you're only making 50% of the glutathione you should be making, it reasons to stand that when I check your glyphosate level, it's going to be off the charts. Because we all have glyphosate exposure, all of us. It's in all the agriculture products. It's in wheat. Unless you eat fully organic, you're going to get glyphosate. So when someone comes to me like this, and this is one of the wealthiest patients I've ever seen in my practice. And I have some pretty wealthy patients. I said, wow, you're taking time bomb from lymphoma. And this is why you're overweight. And this is why you're tired. And this is why you have no energy. And this is why you have brain fog. And we cleared it. And you can see over time how we cleared that glyphosate level. So we have measurable, accurate labs. We know how to check it, but it's not standard of care yet, which I think it should be one day. And you know what happened to this gentleman when we cleared his toxins? I'm not as achy anymore. I wake up, I'm bright-eyed and bushy-tailed. I don't have brain fog. I don't have joint pain. I feel better. Shocking, because you were being poisoned, you know? Common sense situation. Now, what's the $50 billion elephant in the room? Of all those listed diseases, I don't think you guys would have guessed it. Because, oh, maybe it's obesity. Nope, it wasn't obesity. Parkinson's. Parkinson's. So let's talk about that for a second. So the total cost, financial, including medical and non-medical costs, about $50 billion annually. Mayo Clinic also recently put an article out showing the incidence over 30 years has gone up significantly. So if you look at this, right now, if you're over 70 years old, you have a 1 in 4 risk of having Parkinson's. That's insane. That was never the case. It used to be 13%. It's got up 17%. And every 10 years you live past that, now you are 35% higher risk for Parkinson's. So 1 out of 3 people, right, that are older are going to have Parkinson's. That's disturbing. So why? Well, we have plenty of studies here that show you it's pesticides. I don't know if you guys have heard the famous paraquat situation. That lawyers were all over that. If you were exposed to paraquat and you had pesticides, you can sue paraquat. It's not just paraquat. It's all these pesticides. If you have carbamate type pesticides, 500% increased risk. If you just have regular pesticides, 2-fold risk, 200% increased risk. And as you can see, this is concerning. So now we're going down the depressing route a little bit more, but I promise there will be a positive spin to this. Broccoli, when we overfarm our vegetables, we get less nutrients. People come to me all the time, hey doc, do I really have to take that multivitamin? I said, I don't know. Let me check your nutrients. 9 out of 10 times, they have to take the multivitamin. Some people are just like, I know this one gentleman, he would just take in spirulina by the handful and just every day like and he was the only person I knew that had normal vitamin A, vitamin E, vitamin C, because it was packed full of fine nutrients. Most people, you can eat all the salad you want, you can have all the broccoli you want, you can have all the carrots you want, you're going to be deficient. God forbid, you're also inflamed. You have gut issues, you have acid reflux, you're on acid blockers. Now you're not absorbing anything, by the way. So, but look at broccoli. In 30 years, it's dropped anywhere from 20 to 75% the value of all the nutrients across the board. That's concerning. So now we're going to get into the positive part of this presentation. How do you fix people? What do you do? So I had this woman I worked with. She was super nice. She was about 30 years old. And she told me she has 7 years of soul-crushing, that was her words, soul-crushing migraines. And I've never had a migraine. I've had headaches, but I could imagine when you can't work and you're vomiting, I could imagine how bad it is. She worked with me 7 days on, 7 days off when I was a hospitalist, okay? So she worked 12-hour days, and despite using all the traditional standard of care, preventative therapy, which is daily medications, plus abortive therapy, she still had 4 migraines a week. This is what she lived with. Now, obviously it was worse when she was working because the stress worsens it. She went to 3 neurologists. She started taking Elavil, which is standard of care, which did help her reduce from 5 to 4, so it did help. Imitrex, Relpax, Excedrin as needed, which obviously help in the abortion of the headache. And high-dose magnesium did not help. So she came to me in desperation. She knew I was studying functional medicine. This is one of my first patients I ever treated. This is like 10 years ago. So I said, look, let's run your genetics, see what happens. And when I ran it, the first thing I saw was that she had these MTHFR mutations. Now, if you guys have ever studied genomics, this is very common. And I'm going to show you this with a laser here, 44% of the population has 1 copy. 42% of the population has 1 variant. So if you had no variants, this would be white. Yellow means you have 1 bad variant, which means MTHFR basically stands for methylene tetrahydrofolate reductase. So you activate folate by reducing it. So as we know, when we're babies, we need folate as the prenatal vitamin to develop your brain. As an adult, if you don't have folate, your brain malfunctions. ADD, depression, anxiety, attention problems, migraines, headaches, seizures, all of that. So it just makes sense that if you can't activate folate so well, you're going to have to take spinach by the pounds every week, and that's just folate. You still can't activate it into methylfolate. So I said, well, is there any research on this? I understand the concepts, but let's see what I can find. And I also kept looking at these other genes, and I go, okay, this gene means that she breaks down adrenaline a little bit slower, and she's stressed. That's not good. And this means, this one here means she needs a little bit of vitamin B6. And so I kept looking at, and I kind of looked at everything, and I said, oh, this is interesting. 2% of the population has this one. It means you can't activate B6. B6 is a very common vitamin. So I said, you probably need a pretty large dose of activated B6. And so this is her, her complete analysis. And even though these are very common, these genes, to have one copy of each is only found in 12% of the population. So maybe this is the 12% that has migraines. We don't know. So I said, okay, I'm going to explain the science. It's very, very simple. But basically, when you have protein, when you eat protein, it turns into methionine, and that then turns into homocysteine. Then this has to then be urinated out or recycled back into methionine for muscle production. The problem is when you have a problem with these genes here, or CBS here, so she would not pee it out, and she would not flush it back into methionine, she'd accumulate homocysteine. Homocysteine is very toxic. So I started researching it and go, yeah, look, there's research. Here it is, MTHFR for migraines. Why isn't this taught in medical school? I don't know. What about this one? Oh, there's another study there. Yeah. So we do know that there's an association. And then, so what I said is, well, what's going to hurt you? These are vitamins. They're B vitamins. You'll urinate them out. You're not going to, there's no toxicity here. Methylfolate, methyl B12, B6 activated, a methyl donor, TMG betaine, riboflavin, magnesium, zinc. I gave her an herb called ashwagandha to reduce her adrenaline. And this is what I like what I do, because without genomics, you can't do this. You can't tell people what's actually happening. So 2 weeks goes by. I still remember this like it was yesterday. She was blown away. She hadn't had a migraine. I thought it was placebo effect. She thought it was placebo effect. 4 weeks later, I still don't have a migraine. I feel amazing. First time in 7 years, I felt normal. She weaned off her Elavil, which is impressive. She said she couldn't believe she felt so good. She called it a miracle. I still didn't believe her. I kept following up with her, like, are you still, because this is really happening? 12 weeks, you've cured me. Then she wanted to work for me. She goes, this is incredible. Do you need assistance? And I was moving to Naples at the time, but otherwise I would have probably worked with her. She was great. But the point is, what ended up happening here was in a year follow-up, she told me that in general, her migraines were improved by 80%. Every so often, if she ate the wrong foods, had a lot of coffee, or did something weird, she'd get a migraine again. But she was no longer on Elavil. She didn't need it. And she only used the abortive therapy as needed. Now the question is, what else did I do? Was homocysteine just about the migraines, or did we do something major with her? So I started looking at what homocysteine does. And in medical school, you're taught it's a surrogate marker for B12 deficiency. That's it. So if you're not sure if they're low in B12, you check a homocysteine. If it's high, you give them B12. That's it. That's all you're taught. That rarely occurs. Most doctors don't have the time to check homocysteine. We're too busy. You're seeing a patient every 7 minutes. I see 7 patients an hour. 7 patients in a day. I spend over an hour with each one of my patients. So I have the time. I'm like, okay, let's look at some stuff. Cardiovascular disease, stroke, migraine, neurological disease, Alzheimer's, Parkinson's. Who in this room has had their homocysteine level checked? 3, maybe 3. Okay, this is concerning. Cancer. Now, this is really weird. I have a lot of friends that are oncologists. I'm like, hey man, when you were in med school, did they tell you about homocysteine? They're like, no. I was like, okay. So what about this study right here? You ever heard of a publication called Nature? It's pretty important. They published this in 2019, that there's an association with cancer. What are we doing about this? And well, what kind of cancer? Oh, just those. Breast, pancreatic, colorectal, lung, GI, leukemia, ovarian, esophageal, cervical, head and neck. Just to list a couple. And that is expanding because what happens is if you don't methylate well, MTHFR, you don't also methylate parts of your DNA correctly, which means you don't stabilize that DNA. If your DNA is not stable and it mutates, you get cancer. That's the definition of cancer. So this is a huge preventative thing that really has not been looked into. So then we're getting to Parkinson's, a $50 billion elephant in the room that no one thinks about. It's so common. This gentleman was he was really good friends with Bill Gates, Steve Jobs. He developed major companies, major software, major hardware back in the 70s. He was very smart. He came to me, the smartest guy I probably ever met. But he couldn't talk. He had Parkinson's. And as you know, when you don't have Parkinson's, you're frozen. You can't express yourself. You're just like a frozen mask, and you're frozen. You can barely walk. And he kind of shuffled into my office like this. And I said, from a mile away, I said, oh, yeah, you have Parkinson's. What are you doing about it? He goes, well, I haven't started medicine. I said, why not? You can't even move. He goes, well, I want to see if you can find something that caused this. Because doctors treat the symptoms, but they don't treat the cause. I go, well, I can see why you're in my office. I mean, I don't know if I can help you or not, but I will look. I'll run every test I have. So we did. And by the way, I want to mention that he had IBS diarrhea type, okay? Now, if you've ever read about the second brain, there's something about the second brain, the gut being the second brain. When you have gut inflammation, it controls neurotransmitter production. 70%, not 30%, 70% of the neurotransmitters are produced in your gut, not in your brain. So that's really key. So when your gut's not healthy, you're not going to feel good, and your brain's going to suffer. So I unleashed the genomics. I was trying to be like Neo. And I said, okay, so you produce enough glutathione. You didn't have the other genes. But you have an arm, it's an arm of glutathione that's broken that takes arsenic specifically. So this is an arsenic clearing transferase. He had problems here and problems here. And then on top of that, to make matters worse, he couldn't get the toxins out of his brain. That's a problem when you have Parkinson's. So the efflux transporter that takes mercury and takes metals out of your brain is broken. So it's like the front door is broken, and you have a flood, and you try to get water out of your house. This is what happened with us in Naples, by the way, Hurricane Ian, horrible. This is a problem. So I said, okay, what about your pesticides? His pesticides were perfectly clear. Now this guy had, I don't know how many houses, reverse osmosis filters on everything, organic, chef, everything, clear. I said, okay, you have no pesticides, that's impressive. And, actually he had a little bit of this, a DDE, which is an exposure, but it's so mild. In 95th percentile is 12.1, and he had less than 0.4. I wasn't worried about this. I said, okay, this is not your pesticides. Then I checked his heavy metals. I was so blown out of my socks. I've only seen arsenic this high twice in 10 years. The Department of Health calls me. They're panicking, wondering if someone's trying to poison this guy. And I said, no one's trying to poison this guy. So they didn't launch the massive investigation. I swear to you, this is ridiculous. His chef, who fed him all organic food, he liked jasmine rice. So he was getting his jasmine rice because he had the money for it, imported, okay, from Thailand or from Asia, somewhere in Asia. It was contaminated with arsenic. And he had been eating this contaminated Asian rice for years. And this is the problem. He had the wrong genetic makeup. If it was someone else, they would have cleared the arsenic. But he accumulated it and bioaccumulated it. And then the mercury was because he liked grouper, he liked sea bass, he liked the big fish, tuna, halibut. And so I said, well, we're going to have to work on this. This is impressive. And so I scratched my head, and my job is to research everything. I said, is arsenic associated with Parkinson's? So I did a quick PubMed search, and boom, there you have it. They took, some scientists, some labs somewhere in the world, took arsenic plus dopamine and realized that when you combine them together, you destroy the dopaminergic neural cells. That is the pathogenesis for Parkinson's. So we have here a hypothetical model that no one's even talked about, proven. So I said, well, what else did we find in our genetics? Because this is really interesting. And then I realized, oh my God, you're also 5% of the population that has this problem producing an enzyme that breaks down histamine. So let's think about that for a second. Everyone has allergies. When you have an allergic reaction, you get a histamine exposure. You get a hit by a bee and your arm swells. That's histamine, right? Nasal congestion, histamine. You take antihistamines, makes sense. So when you eat food, some food has histamine in it. What kind of foods? Foods that are laid out. Foods, for example, champagne, wine, aged cheeses, sauerkraut, anything fermented, kombucha, yogurt. So if you have a high histamine food and you eat it and you can't break it down because you lack the enzyme, that ridiculous amount of histamine causes diarrhea. It just flushes everything. It can cause reflux, it can cause IBS, it can cause diarrhea. So I'm thinking, oh my God, is this why this guy's had diarrhea his entire life? You know, I don't know. So this is what I found. When I did his labs, his thyroid was all messed up, his vitamin D was horrible, his cholesterol was horrible, his homocysteine was toxic, his testosterone was low. I said, okay, let's chelate you. What's chelation? That's not taught in medical school, by the way, it's not taught. What's chelation? I give you a pharmaceutical drug called DMSA, which is super safe, oral, once a week. That's all I'm gonna do. Very gentle. Over 6 months, we're gonna remove all the metal from your body. So we did it. As you can see, post-chelation, his arsenic was completely normal. His mercury, completely normal. He had a little bit of lead, but I don't really care. Everyone has a little bit of lead from showering in water, and the pipes from the city bring lead to your house, and the lead goes through your skin. It's not a really big deal. That's not a bad level. If you have a lead of 100, I'm concerned. So I said, okay, we're done. We chelated you. Look what happened to his body when we chelated him. His thyroid, which was bad for 2 measurements in a row, completely normalized. So now he doesn't need thyroid medication. That's interesting. His vitamin D, well, we replaced it. We pushed it up. We gave him the methyl B vitamins, methylfolate. We fixed his toxic homocysteine level. Look at his testosterone. Now, this is interesting. 400 to almost 700, 600. That's just from getting toxins out of your body. So this toxin hypothesis is strong. Look at his cholesterol, guys. This is without medication, 280 to 200. That's insane. That's an 80 drop. LDL went from 180 to 130. Any cardiologist in the room would have been like, he's on a statin. He's got to be on something. No, we just reduced his inflammation. That's all we did. At the 3-month follow-up, he literally had no further diarrhea. The first time in his life. No more diarrhea. Fatigue, brain fog, 70% improvement. Mobile, improved by about 30%, his ability to walk. Facial expressions improved by 50%. He was literally unable to barely communicate when I first met him. And the second visit, it was around Christmas, he bought us a $1,000 bouquet of flowers and was singing Ho, 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 Merry Christmas all the way down the hallway. Pretty awesome. I really love my job and I get emotional because it works. It actually works. And it should be standard of care, but it's not. This is an interesting case that if you go to my Instagram, you will actually, this is a CEO of a major company. She was nice enough to go on and tell her entire story. For 30 years, she had chronic fatigue, terrible sleep, fibromyalgia. She couldn't barely walk. She said she walked to her mailbox and she was in pain. She was short of breath. Energy level was miserable. And I said, you know, you've been to 20 doctors. She's been to the Mayo Clinic. She went to Johns Hopkins. Nothing's better. Let's just do something different now. Let me check your heavy metals. This is another woman that had toxic arsenic and lead and mercury. And from Pepto-Bismol, she was using Pepto-Bismol every day for a year, bismuth poisoning. That's why you're only supposed to use Pepto-Bismol for a short period of time, not for a year. There's better drugs if you're going to use it for a long period of time. I think short-term Pepto-Bismol is great, not long-term. So I chelated her. As you can see, her levels coming down. I chelated her again. Levels coming down even more. And we're still on the chelation protocol with her. But what happened a year later? Go to my Instagram, listen to her story. Literally, completely resolved. No more chronic fatigue. No more fibromyalgia. Completely resolved. In fact, she had 7 or 6 businesses that were affected by the hurricane. And she texted me the other day, and she was like, I cannot believe I was up for doing 24 hours straight, fixing the torn roof, and I have no pain, no fatigue. I feel amazing. So this is the power of detoxing. So this is another case. I like to say this in the room in case there's any CEOs in the room that are high stress. This is a gentleman that was CEO, and he had, we were talking at the Tiger 21 conference, and he came up to me, he's like, look, I'm on like 3 different blood pressure medicines, and I can't get my pressure under 100 or 150 over 100 on 3 different medicines. And this guy was like the picture of health. 30-inch waistline, exercise every day, ate really healthy. I said, you're just stressed, you're a CEO, you know? That's what everyone said. He goes, yeah, but my cardiologist thinks I'm not taking my medications because I can't get my medications down. I said, what are you on? He's like, I'm on a beta blocker, calcium channel blocker, diuretic. I'm like, yeah, you're on standard of care. I would have done the same thing. I said, I don't know. I said, let's just run the genetics. I have no idea what's going on. So I ran his genetics. There's a whole hypertension pathway in this tool we have. I said, oh, this makes sense. You're 8% of the population that has an upregulated angiotensin II receptor. So, you know, the ACE inhibitors and ARB drugs, they go down this pathway. But what happens is when this gentleman makes ACE enzyme, it binds 3 times stronger. So the receptor like takes that and just signals it stronger and causes him to retain all these minerals, retain water and salt, aka hypertension. So this guy said, oh wow, you actually need an aldosterone antagonist. This is very rare. It's not even standard of care. And when you look at the standard of care hypertension treatments, it's beta blockers, calcium channel blockers, ACE inhibitors, diuretics. Aldosterone antagonists are not even in there. Because again, this is only for 8% of the population. So I said, take this. And then this says you don't get a response to beta blockers or ARBs, so let's stop the beta blocker. So I told him, look, I'm stopping everything. I'm stopping your beta blocker, your thiazide, your calcium channel blocker. I'm putting you on ACE inhibitor, and I'm putting you on an aldosterone antagonist, because that's what you need based on your genetics. Done. That's all he needed. 6 weeks later, perfect blood pressure. I only saw this guy twice, because that's all he needed. And he's perfect now. So this is the power of the matrix, the power of genomics, the power of looking through, understanding the code, our DNA, our blueprints. And this is a quick one I go through real fast, but this gentleman had reflux, IBS for 7 years, terrible, or 10 years, it was a long time, and psoriasis, and no one knew why he had all this stuff. He had diarrhea all the time, and he was on 3 different acid blockers. He went to a GI doctor, had a traditional workup, everything's normal. They told him, you don't have celiac, you can eat all the gluten you want, we're not sure what's causing this, but every 10 years we're gonna have to go in your stomach and dilate your esophagus because your esophagus is burned. And by the way, you have a higher risk for stomach cancer, esophageal cancer, and by the way, you're gonna have to be on antibiotics for the rest of your life because your scalp's on fire, you have this weird rash we can't figure out. And by the way, you're probably depressed now because you're on 5 different medicines and you're 30 years old. So, and then on top of that, he still got reflux, even if he did like sit-ups or ate the wrong food, he couldn't have coffee. So he wasn't really having a great life. I ran this, and all I had to say is this one gene is all I needed to see. He had the highest celiac risk gene, period. The interesting part is that this gene right here is common in 20% of the population. 1 in 5 of you have this. You're not aware of this. So if 1 in 5 of you have reflux in the room, what if it's from this? And we're not aware of this. But to traditional medicine is called downstream medicine. So what do? They check the antibody that's produced. So you have DNA that produces RNA that produces antibodies. So they're checking for this one antibody, and if you don't have that, then you don't have celiac, right? That's the current diagnosis, how we do it. Or they look in your stomach, they go into your intestines, they take a piece of your small intestine, and they go, it's not completely destroyed yet. You don't have celiac. This is what happens in celiac. You have normal intestinal hairs that absorb nutrients, and it gets destroyed by the antibodies. So this gentleman had the highest risk gene for gluten intolerance. So all I said was, well, why don't you go gluten-free? And by the way, psoriasis could be from gluten. And IBS could be from gluten. And reflux could be from gluten. So I'm not going to put you on any vitamins. I'm just going to tell you one thing. Go gluten-free for 2 months. But you know how hard it is to go gluten-free? I was like, go gluten-free or I'm not going to work with you. 2 months. That's all we're doing. And he was so sick. He's like, I'll do anything. So what happens? He comes back, no reflux in 1 month. Now he's still on medicine. I said, get off the medicine now. 3 months follow-up, no reflux, no IBS, no gas, no diarrhea. 6 months later, completely cured, everything, psoriasis, off all his meds, completely normal. And then he was kind of joking with me that he could have ghost pepper wings, as long as they were gluten-free, and everyone at the table would be crying, and he wouldn't have reflux. He got scoped, completely normal. 0 gastrointestinal lesions, completely healed. This is called upstream medicine. We're looking at the DNA. We're not even worried about the antibodies anymore. So this is why I like what I do. And what about mental health care? Let's talk about that for 2 seconds. $225 billion. This is before COVID. This number is probably doubled now. Post-COVID, we're talking about easily 500 billion, easily. So we have all these drugs in psychiatry. They're very powerful. If you guys have ever worked in a psych ward, I have worked in a psych ward. It is crazy how strong these drugs are. You can zonk people out. You can relax them. You can make them feel good or bad. I mean, you can do whatever you want. These drugs are powerful, and they work very well. The problem is psychiatry is the only field in the world that I know of in medicine where they don't check what the drugs are doing to you. They don't check. They don't check your neurotransmitter levels. They don't do imaging. They don't do brain imaging. But we have the technology. It's coming around the corner. So this is a PET scan that can actually show you and quantify your neurotransmitters. And do you have enough GABA, which calms you down? Do you have enough dopamine, which makes you happy? Do you have enough serotonin, which relaxes you? Do you have enough epinephrine, which keeps you focused? They can tell you now with advanced imaging. And there's something called Translational Psychiatry Journal talked about this thing about plasma neurotransmitters. Now, PET scans can be expensive. Plasma neurotransmitters, that's cheap. That's a blood test. That means that right now they figured out that if they did this observational study on people that had major depression, if you took 50 patients that were depressed and then 50 patients that were normal and you checked their bloodstream, there was an obvious correlation of neurotransmitters. Very obvious. So why are we using that as a screening tool? You know, hey, you want to buy a gun? Okay, let me check your neurotransmitters. And that might be going a little far, but I'm just thinking, you know. This is the type of stuff that we can do. Now, 18-year-old came to me in desperation. She had a psychotic break and basically in an after-hours activity, and she was diagnosed as having anxiety with psychosis. And she had a history of ADD. She was taking Vyvanse for focus. And she said she didn't admit to be using marijuana. Now, she didn't think it was laced. She had used marijuana before, but then all of a sudden, she was delusional. And she was in a hospital for 3 days. Now, this is an 18-year-old. Very young, very pretty, very sweet girl, all of a sudden placed on heavy psychiatric medications. She gained 25 pounds. She went from 120 to like 140 pounds. And she was depressed. She was tired. She was flat. She didn't have energy. She didn't have no enthusiasm. She was very depressed. So although she wasn't psychotic on the meds she was on, she was depressed and had no hope. So I don't know which is better, okay? They're both pretty bad. So then I ran some tests. I said, okay, you have anxiety. Your score is 11. By the way, what that means is that she has the technical definition of generalized anxiety disorder, which is not good. And so I said, let's look at your genetics. Let's do what people have not done. You've already seen traditional psychiatrists. Then I looked at this and I said, oh, look at this. Okay, you're 30% of the population that your serotonin receptor, which is supposed to help you relax, when the serotonin binds the receptor doesn't signal very well. It's like you're firing blanks. You know, the serotonin rolls in and then the receptor doesn't fire. Maybe it fires every other time or every third time. So what does that mean? You're going to get much less calming, relaxing feelings. You're going to be more stressed. You're going to be more anxious. So it's good to know. And look at this. It gives you a 2.8-fold risk for major depression and anxiety, because depression and anxiety both occur when you don't have enough serotonin. This is why SSRI drugs are huge. So I said, okay, is there data on this? And sure enough, there's a ton of data on this. The genomics are backed up. It's a study on 1,000 patients, okay? You keep looking. Other genes she had, TPH1, lower brain serotonin manufacturing. That's a bad combination. So when you have turkey for Thanksgiving dinner, turkey has tryptophan in it. Tryptophan should turn into 5-HTP, which then turns into serotonin. But these people, they cannot turn tryptophan into 5-HTP. They don't convert it. So when they have Thanksgiving dinner, they're not calm and relaxed. They got to go for the alcohol to get calm and relaxed. So the point is, for this person, why don't you give them the intermediate? Give them 5-HTP. It's an amino acid. Or give them an SSRI, but they need more serotonin. As you can see, panic disorder, 1.4 odds ratio, just if you had 2 copies. Now she had 1, but even 1. Suicidal behavior, 1.2 odds ratio. So this is significant. Now when I first met her, on the drugs she was on and on the supplements I was putting her on, we jacked her serotonin up really high. okay, as you can see here. And I backed it down on the follow-up 3 months later to a more normal level. But the problem with that is, and this is what a lot of people don't know, when you're on the SSRI for a long time, I'm sure you guys know people that are on antidepressants, and they're like, man, at first it was amazing. I felt more relaxed and more calm, and then 6 months later, I was like numb. I was numb. Well, what the heck does that mean? I don't have pleasure in life. I'm not smiling as much. I'm not stressed anymore, but why did that happen? Because when you drive serotonin really high, you drop dopamine, and we're going to talk about that in a second too. Now, look at this real quick. This methylation thing that she had, even though it's in 42% of the population, it just fans the fire. Because guess what? MTHFR is required to make serotonin. She needs that, right? Dopamine for happiness, pleasure, and all these neurotransmitters. So I addressed this. Here's the MTHFR major depression link. And the last thing I'll talk about is her last genomic here is monoamine oxidase. So this breaks down neurotransmitters. This is upregulated, so it actually works better. This SNP makes it work better. So she breaks down dopamine faster. So what happens to her dopamine level? In the gutter. Dopamine makes you happy. So when she came to me, she was looking like a Parkinson's patient because Parkinson's patients have low dopamine. That's why you give Parkinson's patients dopamine. So the way you remember this is if you don't have enough dopamine, you're frozen, you're flat, you don't have much facial expression, and you can't move very much, and you're depressed. And if you have too much dopamine, you're schizophrenic. So when she had a psychotic break, what did they put her on? Antipsychotics. What did that do? Dropped her dopamine to the ground. That's why she came to my office going, hey, I don't feel good. And also, look at her epinephrine and norepinephrine. You can see that once we fixed her, she started climbing in the right direction. And so what I'm trying to say, and I'm going to show you real fast, is you can see the before and after on the dopamine improved just by putting her on Wellbutrin, which is an antidepressant that increases dopamine. So this is called precision medicine. This is not done. No psychiatrist does this, which blew my mind. The people that created this panel with the team from Harvard were psychiatrists. But this is not traditional yet. It's not standard of care. So I guess what I'm showing you is the potential we have for not stabbing blindly. So what happened to this girl? Why did she go psychosis? Because people that are schizophrenic have high dopamine. She does not have high dopamine. So this is probably drug-induced psychosis. So she was using marijuana. Some people, when they use marijuana, they can become psychotic. And serotonin can also cause psychosis in rare cases, not just dopamine. So I'm guessing she used marijuana and she had Adderall. The combination put her into a psychotic state. They assumed, never assume anything, they assumed her dopamine was high, put her on antidopaminergics, dropped her dopamine to the floor. Then she got depressed. You see the problem here? So what we did was we flipped everything around, we normalized everything, and of course, she feels amazing now. She went from 4 psychotic episodes in her first visit down to 1, down to 0, and her anxiety went from 11 to 7, and now she's happy, she's motivated, she lost 20 pounds from the drug that she was not supposed to be on in the first place, and she feels better, and now she's back. So this is my salvage moment where we said, finally, we did something right. So this is, I really appreciate you guys' time. I wanted to showcase the future of what I consider genomics and advanced testing and environmental medicine. And I'll leave you this quote here. And this is just another follow-up of how much better she was doing. But every time you're tempted to react in the same old way, ask if you want to be a prisoner of the past or a pioneer of the future. Thank you, guys.